When you three showed up today, you had a mask on. You had a mask on, Kwame. Isaac, you did not. And I want to have a little bit of discussion here about why you made those decisions. You want to start us off?
No. I'd love to hear what they have to say first.
Okay, fair enough. Dawn, why did you have a mask on?
For me, there's sort of a mix about my duty to the people I study and care for. So I study vulnerable people and older adults in long-term care, and it behooves me as a young person to prevent the spread of infection to the vulnerable people around me. But I'm also concerned about my own health. I am in the prime group for getting long COVID. That's 40 to 60-year-old women. And as well, even if it wasn't long COVID, having a serious respiratory infection does contribute to long-term health issues. So I think of it as easy, it costs me nothing, it's an investment in my health. And lastly, I did not want to get sick and infect you because you need to be doing the great work that you do.
Oh, shucks. Thanks, Dawn. You can come back anytime. Kwame, why were you wearing a mask?
Very similar reasons. Masks protect you, but they actually have a bigger protection for other people. And I think it's important that when we have a public health emergency, like COVID, I mean, we're still talking about 50 people dying in a month or 600 a year. These are preventable. And if there's a small, easy thing I can do, which is put on a mask to help prevent the spread of the virus, that is something that I will do day in, day out. I don't like wearing masks, right? But it's a simple thing to do in public. I came in, you're wearing a mask, I put on a mask. I get on the subway, I put on a mask. I think it protects me, but it's also my duty to others.
This is not about mask shaming here, just so you know, but you were not wearing one. How come?
No, I wear masks in certain situations, but certainly not all situations. We know what masks do. We also know what they don't do. And of course, they can reduce an individual's risk of getting an infection, and that's important for a variety of reasons. We also know that it can protect other people if someone is infected and they're pre-symptomatic or even symptomatic and able to transmit this infection. I work in an acute care hospital. I put on a mask frequently in hospital settings, not just to protect myself, but of course to protect those around me. But I don't wear a mask all day, every day, in every interaction. I know what the data is. I know what the strengths and weaknesses of the data are for risk of infection, risk of chronic complications of infections, risk of transmission. And I think at the end of the day, I think what our duty is really to enable people to make smart decisions for themselves. And some people will choose to wear a mask. Some people will choose not to wear a mask. Some people will choose to wear a mask in various situations. But I think if we enable people to make good decisions for themselves based on their own risks, and as you pointed out, you know, the risks might not just be to that individual, but to their household and family members, I think we're doing something right.
Let me pick up on that, because you had the mask on when you came in. You are obviously not wearing it right now. I say that for people listening on podcast who can't see. Are you taking an inordinate risk by taking the mask off right now? We are sitting 2 feet away from each other. What do you think?
Well, I think, you know, we're in a big airy room. There's not very many of us in this room, so I'm not really worried. On the subway, I will be masked because that's a really different situation. So I think it is about risk. I mean, we all have to make decisions about how much socializing we're comfortable with mask on, mask off. You know, if you think of having a risk sort of budget for the day and the people you want to protect, I want to keep myself as protected as possible so I don't infect the people I care about, so I can spend more time with them unmasked, especially the vulnerable people in my life. So it's a risk assessment. Some people wouldn't be comfortable with this level of interaction, and I would encourage them to keep their mask on. I'm comfortable with this level.
Got it.
So that's my decision.
I mean, very similarly, I thought about it and thought, should I have a mask on in this conversation about COVID to make the point about the need for masking? But as you say, you have to balance the risk, but also can anybody understand you?
Yes.
But it's interesting when you do things like the Emmys, the Oscars, those big occasions, they all have COVID protocols. And when they shut down their COVID protocols for the Olympics in summer, they started having problems. So it's interesting. People are doing risk assessments and coming up with risks. You know, if you can't be shut down for 6 weeks because that will shut down a $500 million film, you know,
that's pretty serious.
People decide they're going to take a different risk assessment. Yeah.
Can I add one thing to this? obviously no shame whatsoever for whatever people choose to do, and appreciating that everyone has different risk thresholds, risk perceptions, risk calculus, that's important, and appreciating that different people are going to do different things. Fine. Part of that calculus is we have some tools to help reduce the risk of infection. They're not perfect, but they're good, right? Masks, we know improving the quality of air in indoor environments is helpful. Is it perfect? Of course not. We know vaccines are helpful, but of course they're not perfect. But also factored into these equations are, this is never going away, okay? This is for forever, and I think that needs to be acknowledged, right? And of course we should take tools to help reduce the risk of infection, but this isn't something that's going to be over in the next year or the next 2 years.
Let me pick up on that. Do you think we, and when I say we, I mean not just the public, but governments, everybody responsible here, not you, but others, have become somewhat complacent about COVID now because we are not, we haven't shut down schools, we're not shutting down cinemas, malls, and all that. We're kind of sort of back to normal otherwise.
I think complacency is a huge problem. I think one of the things that I wish we'd done differently during the pandemic is we reported so much about deaths and hospitalizations. I work a lot with older adults, and for older adults, sometimes dying is not the scariest thing. It's losing independence and the ability to live a good life. When I see those hospitalization stats, every number there to me is a family who's going to struggle to help their loved one get back to the level they were. When you're middle-aged and older and you're in the hospital with a serious infection, COVID or any other infection, the chance of going back to the life you once had is small, and we don't have the resources to do that. It's estimated that only 2% of Ontarians get rehabilitation care, which is evidence-based practice for recovering from a serious hospitalization. Our family practices are completely overwhelmed because one of the things that happens post-hospitalization is what's called increased medical complexity. You might have a heart attack next. You might need some help getting mobile again. So the complacency here upsets me because it's straining so many of the other systems, and we're not putting two and two together and attributing the stress in our family practices, the stress in our hospitalization, our healthcare worker burnout, to the fact that we have a lot of hospitalization still for COVID because there's a lot of COVID going around.
Who do you blame for the complacency?
I think I will put some blame on government policies. It's hard for people to know how serious it is. And we discussed earlier how hard it is to get a vaccine. As I always say as an immunologist, actually any COVID vaccine provides some protection. So when somebody's starting chemotherapy, maybe they're going to the hospital for a major surgery, there are lots of good reasons why you should get vaccinated right now if you have something like that coming up and you can't. And as well, we don't have access to testing. COVID's an unusual infection because we actually have a treatment that helps keep people out of hospital, which is Paxlovid, but it only works in the first day or two that you have COVID. So without the testing, without the public knowledge about that, without any of us being able to say how much COVID is there around, it's difficult for people to make that risk calculation.
Feels, Isaac, like the provincial government, and I'm going to be careful how I say this, but they're reading the room. They're pretty good at public opinion. And public opinion is, we're done with this. So do you blame them for not leading the way?
I want to politely push back on a few items.
Sure.
Think about the levers we have to pull. Okay, said another way, what are you going to do different? We're well past the era of mandates for vaccines and for masks. Like, that should not even enter the equation, okay? We know this virus is never going away. We know that we can improve the indoor air quality, and there's a big push to do that, and that's a good thing. We know that many people can choose to wear masks, but again, like I said, we're well past the era of mandates. We know that vaccines do not block infection and transmission nearly to what they did earlier on in the pandemic. They still have some capacity to do that, to a lesser extent and for a shorter duration, but the heavy lifting of the vaccine is to significantly reduce the risk of severe manifestations like hospitalization and death. We know that the therapeutics, Paxlovid, based on the most recent data, probably, keyword probably, helps those only at greatest risk for severe infection and doesn't really have much utility in a vaccinated or infected and recovered population that's younger with fewer risk factors. So, this virus is here, and this virus is going to continue to circulate. And we, of course, can take steps to protect ourselves and protect those around us. I think we have to be realistic about what tools we have and the utility of those tools, which is comme ci, comme ça. And, you know, to one other point that's semi-related, thinking that an infectious disease specialist, an immunologist, an ethics expert are going to navigate this, yeah, we're helpful, but like we really need behavioral scientists. And the integration of behavioral scientists into communication, epidemic management, pandemic management is extremely important. Because to your point, you know, how do you read the room? How do you reflect doing the best you can to protect individual and population health with what is the will of the people you're working with? Because that's going to be different in different populations.
Well, let me ask you about what was...
behavioral science, because I'm a psychiatrist. Yeah.
I was actually going to ask you about long-term care homes, because that was ground zero for many people when COVID was at its worst. Have we learned enough? Are we employing what we have learned to ensure that long-term care homes are safer today?
So I'll come to that in just one second, but just want to pick up on something that Isaac said. One of the things we know about COVID at the moment is it's not the same as most infections. It increases the risk of a number of physical illnesses, and there's a risk of long COVID. And the more often you get COVID, the more likely you are to get long COVID. So if this virus isn't going away, then part of the calculation we have to do on risk, and also the calculation we have to do on public policy, is around what happens over a period of time where more and more people have been infected more times, and therefore we have an escalating number of people with long COVID. If you do the math that way, you start thinking that some of the public health measures that are in our arsenal are things that we should be employing more now to prevent the long-term problem. People think COVID's just like having a cold. It's not. And that is our public policy problem at the moment, is the calculation around acute infectious disease is one thing, but the calculation around what you do about a much bigger long-term risk is another thing. And that's where the behavioral science and the psychology comes in. Because, as you said, people are done with this. They want to forget. They want to believe that they've woken up from a nightmare and it's not a problem. But it's just not true.
Okay, how about long-term care?